Okay, I've just been told the recording has started. So I'll start all that again. But so we're starting off. We'll have Tozer and Lillian Reza, hope I'm pronouncing that correctly. And they're both from St Mark's, giving up their time tonight to talk to us about Setons, everything about Setons. So the structure of the evening is going to be a couple of presentations first, and then some of the questions that have been sent in already that we've collated from the two groups will be asked and dealt with by our guests, and then there'll be a little bit of time at the end for questions that come through the live chat. So about the live chat, as you can see, your name will come up as guest. So if you want your name attached to your question, then you'll have to write your name either at the beginning or the end of your question. We will collate those throughout the evening and try to deal with as many of those as possible at the end. I'm not sure if I'm missing anything else. I'm seeing that some people are having some trouble with sound, so we might just leave it a couple of moments to see if people can get that sorted. Rebecca, maybe you can indicate to me whether there's a lot of people that can not hear. We'll maybe leave it a couple of moments and then see if people can start to get their sound sorted. So at the moment we are just setting up Lillian's screen. Seems like sound is now getting sorted. If there are people that still have no sound or can't hear, can you maybe just indicate in the chat box? I think we might be good to go. Ah yes, Rebecca's just written, if you can't hear, indicate here, because of course if you couldn't hear, then you didn't hear that little announcement. That was well spotted. So we'll wait and see. People can hear but can't see. Let's see. So I'm going to jump off. We'll probably move over to Lillian in a couple of moments, but just we'll try and sort out some of the sound issues. So if you don't hear or see anything for a couple of moments, we're just transitioning between speakers. So I will see you guys in a bit for the Q&A.
So, my name is Tozer, and I'm one of the surgeons. I work at St Mark's, as Gillian mentioned. And we're going to do a bit of a chat now. This webinar is based all around Setons, but of course it may get wider as questions come in. There are really two parts to it, and the first part is Lillian, who's one of the research fellows at St Mark's, and I talking about a bit of PPI, that's patient and public involvement in research, that we did recently about Setons to try and gain information from you. And that will be over pretty quickly, and then we'll switch to information going the other way. So questions from you, which we will try to answer, and we've got a bunch of questions that have been sent in beforehand, more than 50 in fact, which I'll whiz through as fast as I can. And then any questions that come up during the chat we'll try to address as well, as much as we can do within the hour or so that we've got. So I'm going to ask Lillian now to start by running through some of the PPI work that we did to try and give you a sense of what we want to achieve.
Thanks, Phil. Hi guys, I'm Lillian. I hope you can see my slides. Just to start with, thank you so much for joining us this evening. It's absolutely great to be able to talk to you all. I'm going to talk about our patient and public involvement event that took place last November at St Mark's Hospital. And I'm going to share with you the discussions that we had with patients and what patients had to say about their Setons. We're hoping to have a similar discussion today and be able to learn more from your experiences of living with a Seton. Essentially, what we want to know is what makes a good Seton, and we hope that you can help us provide some answers with regards to that. We think that hearing from patients is the first step towards developing research that will go towards answering that question. Now, just moving on to why we are doing this, why is patient and public involvement important in research? I just want to say that we think patient and public involvement is incredibly important just because it ensures that the research that we conduct is relevant and it's acceptable to patients. It also enables patients to share their perspectives. It allows you guys to contribute to research and influence research that is likely to affect your healthcare in the future. Also, patient contribution improves the quality of research that we do and the methodology that we use, and it makes sure that any of the outcomes that we find from that contribution is impactful and relevant to your care. So, just going to move on to what our future thoughts are and the kind of research that we would like to do in Setons. So there are a wide range of Setons available in clinical practice. There's also variability in clinical practice in the way that the Setons are used. You will all know that there are Setons whereby some Setons have one knot and some Setons have multiple knots. There is no evidence to show which is better, and there's no evidence to show that which one of the Setons is the best for us to use. We want to develop a clinical trial to compare Setons and establish whether there is a Seton which performs better than the rest. The information and knowledge that we gather from this event and from the event last November will help us develop future clinical trials in Setons. The aim is to find out from patients what they think makes a good Seton. And in order to do so, this sort of event is the best way to start asking those questions. We also want to know what qualities of a Seton make it a bad Seton and what experiences patients have had with their Seton so far. So I'm sure you've all had various experiences with Setons. We started our PPI day in November asking one simple question: is your Seton comfortable? And what we wanted to know is, can you tell us what makes your Seton comfortable, or if it isn't comfortable, what are the features of a Seton that make it uncomfortable? So in terms of the Setons out there, we have Ethibond, which is a very common Seton. As you can see, this is the blue Seton. I'm not sure if you can see my cursor. So Ethibond is a very common type of Seton, and vascular sloop, the red Seton over here. They're commonly used in clinical care. Vascular sloops are made up of plastic, while Ethibond is made up of a polyester material. We asked patients with experience of these Setons whether they found the material comfortable. We found that most patients had experience of only one type of Seton, therefore they were unable to compare these two Setons in terms of comfort. Both Setons caused varying degrees of discomfort for individuals, therefore no one Seton came out as being better. Overall, patients suggested to us that they would prefer a Seton which is made up of soft material that did not cause chafing on movement. What we found was that most patients actually disliked very long or very loose Setons, which can catch clothes, cause chafing, and are very difficult to keep clean. Patients also emphasized to us that the type of knots and the number of knots were greatly responsible for discomfort. So, moving on to talking about knots, which I think we will find is incredibly important for those of you who've had Setons. Ethibond can be secured in place with multiple knots, like so, or it can be secured in place with a single knot. With multiple knots, you often find these long tails. Very similarly, vascular sloops can also be secured with multiple knots, leaving long tails, or they can be secured just by overlapping the Seton and using silk material to suture it close. Now, we have found from patients that the most common effect of a Seton seemed to be pain, and this was attributed to the following: big bulky knots, multiple knots, braided knots were much worse than single knots. Long tails were also found to be very uncomfortable, and some patients talked about internalization of the knot, where the knot in itself disappears into the fistula tract, and this can cause great discomfort if you have a raw wound. So just following on from that, we talked briefly about knotless setons at our PPI day, and we found that only one patient out of 16 had experience with the comfort drain. None of the patients we spoke to had any experience of a super seton. As of yet, we have very little evidence to say whether these setons are any better than the setons we currently use, such as Ethibond and vascular sloop. The one patient who had experience with the comfort drain did say that their seton was better than the Ethibond they had experience with before, but also the main worry about comfort drains and super setons are that they can easily detach, and of course that would mean going back to surgery to have another seton put in. Now, we wondered what actually makes a good seton. So what would be the perfect seton for you? And we asked our patients this question. They told us one thing that they were very clear about was no knot or very small knots would be something that they felt better than having multiple knots or long tails. A seton, however, needs to be secure, because of course if it isn't secure then it might mean that it falls off and you'd have to go back to surgery again. Knots on the outside were preferred. Knots which were made up of smooth, soft material were preferred. Patients also suggested to us that one seton per tract was much preferable than having multiple setons through a single fistula tract. They also wanted to make sure that the seton didn't easily fall out, but also would help them engage in physical activities and day-to-day life. The main thing that patients suggested with regards to the seton is that a good seton should prevent abscess recurrence and prevent multiple admissions to surgery, which we think is absolutely a fair enough point, and that is exactly why we are using the seton in the first place. So moving on to impact on life, we asked our patients how the seton itself has impacted their day-to-day life. We explored in detail the impact that setons have in various aspects of life. We know that setons affected people in different ways. The severity of the impact varied. Some of the negative experiences were attributable to the fistula rather than the seton itself, and it was really important for us to really tease out what effects were of the seton and what were actually arising from the fistula itself. Because in the future, if we are to develop a new seton or to find out what makes a good seton, then we will be aiming to improve the characteristics of the seton rather than the fistula itself. So looking at what parts of a patient's life is mostly affected, the first thing that came out to us, that spoke up to us, was hygiene. Personal hygiene was a universal concern amongst both men and women. We found that patients reported multiple knots, certain seton material, loose setons, long tails were more difficult to keep clean. They suggested to us that seton materials that do not easily dry could smell and could become dirty very easily. Mental health was another aspect that we found was greatly impacted by those who were having to live with a seton long term. Depression, anxiety were common themes that young women suggested to us stemmed from having a long-term fistula and a seton. This often impacted their well-being and ability to engage with their family and friends. They often suffered a feeling of shame associated with the seton. And unfortunately, what we found is that a lack of preoperative counseling meant that a lot of patients were not able to really cope or come to terms with having a long-term fistula and a seton. And this often impacted their well-being and their ability to engage with their family and friends. They often suffered a feeling of frustration, and they thought that they could never really come to terms with having a seton. Finally, we found, with regards to mental health, that there was very poor support in the community. Patients told us that they found the non-surgical healthcare professionals were less able to support them effectively if they had concerns with regards to their cetons. Another very common theme that was brought up by patients was exercise and movement. Many patients found that pain and discomfort related to a Seton affected movements such as walking, certain exercise such as weightlifting, riding a bike, and even yoga. So we delved a little bit deeper into some things that we probably don't speak a lot about in our professional lives, and this was very important for us to hear from our patients. We wanted to know whether the Seton directly affected people in terms of their employment, their career, their ability to have sex, intimate relationships, and how they felt about their body image. Unfortunately, we found that pain and discomfort from the Seton often prevented some patients to continue to work. And we found that a lot of patients were unable to travel for work, and this stemmed from the fact that traveling meant this might involve sitting for long periods of time, and that would be painful. It also meant trying to access toilets, which may not be widely available, to clean themselves properly. So patients also suggested to us that they needed to change their work environment, such as using a wing pillow or standing desk in order to continue to work in some places. And often employers were not very helpful in terms of ensuring that work environment was made appropriate for them to continue to work. Sex and relationships also had a profound impact. Mainly young women told us that forming new relationships was difficult. They were unable to explain to a new partner what the Seton is, and they often found that the Seton was associated with ideas of shame, and it could be quite embarrassing to explain to a new partner that they have this Seton, which many people outside our community would probably not understand. Social life and body image was also something that came up multiple times in our discussions with patients. Patients suggested that the Seton was seen as embarrassing or dirty, and as a result, they often found it difficult to socialize, knowing that they had a Seton, and they found it difficult to socialize in areas where they wouldn't know if a toilet was readily available, for example. So moving on from here, the reason we are holding this webinar is to make sure that we speak to as many of you as possible and have a larger group of people involved in contributing towards our research. We want to make sure that the questions that we ask are important questions, and they're important to you, and they will directly affect any changes that we bring about with our research and the outcomes that we find. We hope that an online platform will also be more convenient and accessible and allow a wider representation of the group of patients who are using a Seton. We know that today the time may not be enough for all of you to express your views, and which is why I've put up our Fistula Research Unit email. Please do write to us if you are unable to tell us about your Seton today, and you have specific things that you want to share with us, or you want to share it with us privately in a more intimate setting, then please do write to us. We will read all of your views, and we'll take them into our consideration for what we want to do in the future with research in Setons. We intend to publish and make available the outcomes from today and our Seton PPI Day to others who may be conducting research in Setons or developing Setons, so that they can benefit from this PPI project, and so that they can benefit from the things that you have to say to us today. So thank you so much for joining us, and I will hand you over to Phil now.
Great, Lillian, thanks very much. I thought that was a very clear description of what happened at our PPI Day. I think Rebecca is just going to switch over to me as presenter so that I can show a couple of slides myself. Oh, yeah, here we go. Boom. So I'm just going to ask for one of the other members of the team to just message me to tell me that they can see that they can see my presentation now that that's working. Yeah, okay, Gillian says she can. That's fantastic. So I'm just going to add a couple more minutes because Lillian's talked really effectively and I don't need to do too much else. But broadly what we ended up doing was trying to work out what people mean when they say the best Seton. How do you get the best Seton? Now, on the left of the screen, you can see the functions from my point of view as a surgeon, right? I want it to prevent abscess. I want it to prevent increasing the complexity of a fistula, and I want the tract to mature so that I can try a reparative technique if that's possible. And I want to try and make the fistula symptoms reduce as a result of having the Seton in place. That's what I want. But I spend my day making great holes in people to try and make their lives better, and of course that doesn't always happen. And on the other side of the screen you can see the other side of this. If the Seton is damaging someone's quality of life rather than improving it, then it's doing exactly the opposite of its job. And that was why we were so interested in seeing what the other aspects of the Seton were from a patient's point of view. So what about the symptoms? What kind of symptoms are there that people have, and what was the effect on different aspects of people's quality of life? And so we asked a number of questions. What was good about your best Seton? What's bad about your worst Seton? Describe your ideal Seton, if there is such a thing. And what are the different parts of your life that the Seton affects? How do they affect it? How should we measure that impact? And how can the Seton be changed to improve that? And Lillian has gone through with you some of the answers that people gave to those questions. And these are the questions that we want you to continue to answer for us, either through the chat today or by emailing us. And Lillian put the email address up earlier on. And then, of course, we wanted people to prioritise these issues, because you will all understand better than most people that there is no perfect solution here. It is always the case that we will have to give and take on some things. And the question is, which ones are most important? Which ones are the things that have a greater impact? What's more important? Is preventing an abscess the most important thing? That's the most important thing for me. It may not be the most important thing for you. And that's very reasonable. That's the kind of conversation that we should be having with patients, in my view, in clinic, but also in terms of this research, so that we can try and produce Setons which really are genuinely improving people's quality of life, rather than just keeping them out of hospital. There were one or two other issues that came up in the course of that conversation, and these are some other things that I'm really interested in your points of view on, again, either through the chat or through email later. Does the surgeon's gender have an impact on these kinds of conversations? Because quite a lot of the time we're going to be talking about pretty intimate stuff, including sex. And specifically with regard to sex, we had some people saying that they felt that bringing sex up in a consultation was something they really didn't particularly want their surgeon to do, whereas others felt that it was crucial. My view about this is that we should be talking about sex much more than we do, but not everyone feels the same way. And so we're very interested in your points of view about that. Do we do it too much or too little? Do we do it in too blunt or unhelpful a way? How should we be doing that better? There was an awful lot of people saying that there just isn't enough information about these things. That's come through with the questions that I had before the seminar, the webinar, and also even on the chat so far today. That kind of thing has come up, and that remains, I think, crucially important, and is part of the work that Rebecca and Gillian and Rachel and Lindsay and the rest of the team here are trying to do with regards to this Facebook group, but also the leaflets that we're producing, these webinars and so on. And we also talked about community gatherings, because the 16, 17 people who came along to the PPI day felt that it was extremely valuable, and we wondered whether having information days where a few of us go around different parts of the country and invite people along to have these sorts of town hall meetings where you can talk about these things face to face with us, but also probably more importantly with each other, might be very useful. Okay, that my last question for you from a PPI point of view is about Seton change in a study. Now, if we want to find out what are the best Setons, in the end, the best way to do that is with something called a crossover study, and that is where you have a Seton for a period of time, and then I put you to sleep and change it for a different Seton for a period of time, and you tell me which one is best and why. The problem with that is that you have a general anaesthetic in order to change that Seton, and for some people that's quite a big deal, understandably. And the question is whether you, as the people who will both suffer from these problems and benefit from the answers, take the view that that is something that you would be willing to go through in order for this kind of study to take place. So that's a very specific question. If having an extra general anaesthetic is too much, it's beyond the pale, then I want to know that. If you think that would be a pretty modest problem and people would be willing to do it in order to try and pick out this answer, then I'd like to know that too. That's very useful for us when we think about how to design the study that we want to do, and also talk to the ethics committee, who will tell us that they don't think it is the right thing to do, but they are not patients with fistulas. They don't have Setons in them any more than I do, and they might think they know best, but actually, in my opinion, it's the 75 or so of you out there listening to this and your 2,000 colleagues in the Facebook group and many more people besides who can answer that question rather than them or me. Okay, I'm now going to switch to answering some of the questions which have come in from the group, and I'm going to pause sharing, which I hope I can do, because then I can also see the questions as they come in. Have I paused sharing? I can't tell. I think I've paused sharing. Okay, good. And if I bring up the meeting, then I can see other chats going on. Okay, here we go. So the first question is actually about radiation injury, and it wasn't quite specific enough for me to be able to give a really clear answer, and it's quite niche, so I'll run over it quickly. But essentially, fistulas associated with radiation, for example, if you've had radiotherapy for a prostate cancer or a cervical cancer, or a rectal cancer if it's associated with a joint in the bowel, they're very specific fistulas. They're pretty unusual, and the problem is that the radiation affects the tissues. That's the reason that sometimes fistulas appear, but it also means that the tissues won't be repaired very easily. They don't want to heal because of this thing called endarteritis obliterans, which is where the tiny blood vessels in the tissues don't work well. And as a result of that, you have to really bring healthy tissue from outside the radiation field, which often means quite a big operation. I'm not going to go into that in any more detail. We can talk about radiation fistulas separately another time if people want to. It's quite a technical area, but it affects very few people. Okay, why in general is there so little information, including staff knowledge? And I won't give you too much detail, but several people asked this. And people talk about nurses in the practice saying, oh, I think there's a bit of suture that's been left behind, I'll just remove it for you. And patients yelling, no, no, don't do that, that's my Seton. I think the problem is that fistulas, you know, they're not rare. They affect around 1 to 2 per 10,000 people, and that means they're not common either. And if you think about your GP practice, there might only be 5 or 10,000 people in a GP practice. That might mean 1 or 2 fistulas at most, and that might mean that the practice nurse that you're seeing on a day has never actually seen one. And so they will perhaps not know much about them. I guess our approach to that, and when I say our, I mean all of us in this fistula awareness group in one way or another, take the view that probably educating the patients is the best way, and educating nurses and surgeons and GPs and so on is also part of our work at St Mark's, but the more patients know the better, and that's really the point of the leaflets, the webinars and so on. The next question I'm going to answer is about keeping the Seton and the anal opening clean after a bowel motion. So my advice to patients with this is to use a shower head and direct it up into the anus. So take it off the wall, turn it up underneath, under your undercarriage, and fire it up there to really try and get some irrigation of the wound, the anus from the outside, and where the Seton's sitting. And that should hopefully get things nice and clean. And then people always say to me, well, that's all very well, Phil, but I can't really do that in my office at work, which I guess is true. And in that situation, first of all, don't worry too much if all you can do is wipe. That's okay. You know, if there's a bit of stool around, that's not going to be a disaster for your fistula. It's used to stool. When you get home, you can hop in the shower and wash it down. But one of the patients at the PPI day, in answering, as soon as I was talking about this question, whipped out a little sports bottle with an attachment on top with a nozzle that she could use to wash down the fistula and the anus, a little bit like a portable bidet kind of thing. And people, and she found that extremely useful. I'm sure that's something that might be valuable to other people. And I think there are pictures and Amazon links have been sent around about that in the Facebook group in the past. Lots of questions about pulling, moving, rotating the Seton, and whether that's a sensible thing to do. So in general, it is not a bad thing to do at all, and Setons will move. Sometimes the knot will go inside the fistula, sometimes it will go inside the anus. Those things are fine. It's really only about comfort. I don't take the view that it is a good idea to rotate the Seton, personally. People say that that cleans the tract. I don't know, it's not clear to me that that will make a big difference. There's no evidence about it. It might be somewhat painful, and if the knots are big, I think you don't really want those knots going through the internal opening and making that hole any bigger. So my own view is that you should put the knot wherever it's comfortable, feel comfortable to move the Seton around to keep the knot wherever it's comfortable, but I don't advise people to rotate the Seton personally. I know that some surgeons do, and I'm not saying that that's wrong, but it isn't my personal view. There was a question about Kashara Sutra, which you may know is a sort of chemical cutting Seton, which I'm not going to go into in detail. It is something that I'm interested in as a concept, and my team are looking at the non-allopathic treatments, which is what people who that's what you kind of politely call Western medicine, allopathic medicine. People who are not really into Western medicine talk about all of these other things. My own view is that whatever works, I think we should use, but there has to be good evidence to support it, particularly if people are going to spend money on it or travel across the world for it. And that evidence really is the key. And there is some evidence for Kashara Sutra, but it is not overwhelming. So that is a watch this space thing. Crohn's and Seton. So this is a really good question. I was told by my colorectal surgeon 4 years ago when Seton was placed that due to inability to heal properly stroke efficiently due to being immunocompromised with Crohn's, that having the draining Seton would be a permanent fixture. Is this a standard thought process for Setons and Crohn's? I think the answer is yes, it is. The standard view, but it is not my view now. And during the course of my training and the initial part of my research some years ago, that was exactly what we said. You know, I wrote a review article saying that, but I think as time's gone on, things have changed a little bit, and there are opportunities now to try and close Crohn's fistulas within certain parameters. So there has to be no proctitis, no other perianal disease, and limited luminal disease, and good anal tissues, and the fistula which is simple enough to approach surgically. And that list of things that I've just said is actually quite a big ask. Quite often people will have a bit of proctitis and so on, and all of those are factors which would mean that any attempt at repairing the fistula would be unlikely to work. But if you do have a good setup and it's possible to have a go at repairing these fistulas, then I think we should. And I don't think we do that enough in this country. I include myself in that. But we are trying to do it more and more. And quite often that means offering things like the lift procedure or advancement flap. But it might in the future mean stem cells. We have had access to some stem cells, and we're about to start, along with several other centres in the country, I should say, in the ADMIRE-2 study, which will give us access to a few more stem cells for these patients. And there's always the non-stem cell arm of the stem cell study, which again we could talk about when we're not focusing on Setons and we have a bit more time to think about Crohn's fistulas. It may be good to do a webinar on those specifically. It's quite a difficult question after that about a complex horseshoe fistula with one Seton in and then a second opening appeared on the other cheek of the buttock and on the other buttock, and that may be something that people are familiar with, particularly those who have had horseshoe fistulas in the past. You do quite often get the situation where if you only drain one side, then the other side will start to drain too. And in that situation, a second Seton is the simplest thing to do and involves the less cutting and the less kind of actual active work. The alternative is to drain that horseshoe, but that can be quite a big deal. And if you have a horseshoe that goes around the outside of the anus, then you have to make really quite a generous incision around the back of the anus to get that fully drained. And if the horseshoe is actually in the space between the two muscles, an intersphincteric horseshoe, then you have to drain that internally often, and that means damaging the internal sphincter, which carries its own risk of usually pretty modest impact on continence, but nevertheless a risk of something, difficulty controlling wind, for example. And draining the horseshoe doesn't usually solve the problem either. You still have to lay the the fistula open or do a sphincter procedure. So it's quite a complex setting, but it's a nice question because what the person said is the fistula open with a Seton in hardly ever drains, but the new one is problematic, drains a lot and still causes pain and so on. And that's really the whole point of the Seton, is to sit there to help things drain and to gently mature the tract and let it settle down and improve and the symptoms to settle over time, which happens for some people, but unfortunately not for all people. Now, one of the questions that's just popped up is about how long you can have a Seton. The answer is you can have a Seton forever if necessary. And they will from time to time degrade and break and need replacing, but if there is no fix for your fistula, then a long-term, permanent loose Seton is a very reasonable thing to do, and it should over time produce fewer and fewer symptoms. And they can eventually stop draining through a process called epithelialization, which is a bit like when you have your ears pierced. After a while, you know, you can take the earring out and the hole doesn't heal up, at least to start with, and that's because it's grown skin on the inside of the hole. And the same thing, epithelialization, happens with fistulas eventually, and they continue as a conduit, so stool or bits of food or whatever can come through them, but they're not inflammatory anymore. They're not active and producing pus and causing abscesses and so on any longer. So that's the outcome for Setons in the long term. Now, people always worry that having a Seton in forever might mean that they get cancer. That is not a risk. Okay, I do not want you to worry about that. There is a very, very, very tiny risk of cancers occurring in fistulas in patients with Crohn's disease over a prolonged period of time. This happens. It's very unusual. It's not related to the Seton, and it's a really rare situation. I don't want to frighten anyone about it. But in patients without Crohn's disease and in the vast majority of patients with Crohn's disease, this is not a concern. So I don't want it to be something that makes people anxious, and having a long-term loose Seton is a very reasonable way to avoid seeing surgeons and the inside of hospitals all the time, as long as the Seton is comfortable. And there are a number of questions about why Setons are sometimes not comfortable, and there are two answers to that in my view, and one of them is that it's not the Seton that's causing the trouble. For some patients, there's a bit of fistula which isn't well drained, and people get recurrent abscesses because of that. Sometimes the Seton can cut towards the anus a little bit and leave a bit of the tract undrained, or there can be a high sump, some extra little bit of the fistula which isn't well controlled with the Seton. And in that case, if those areas are drained and Setons are inserted appropriately, sometimes more than one Seton, to make sure that you really get all of those different parts of the tract, then it is possible to get the pain and symptoms associated with the fistula down. And the other answer to that question is that the seton itself can sometimes cause trouble and be painful. Sometimes the knot goes inside the fistula, and for some people that can be painful and they should rotate it out. For some other people, the seton rubs and chafes and causes trouble, although again often that's the discharge that's causing the chafing rather than the seton or the knot itself. But the setons can be problematic, and in some people they are simply not tolerable. And in that setting, obviously the surgeon and the patient have to come to an agreement about what is the lesser of the various evils available to them. And sometimes that will be to stick with the seton even if it's sometimes uncomfortable, and sometimes it will be to take the seton out and put up with an abscess occurring from time to time, which of course it might. Okay, lots of people asking about what you can do with a seton and what you can't. People worry about swimming. Swimming is fine. Okay, people worry that the water will infect the fistula. Well, the fistula is full of poo and pus. There's not much worse that you can get in there. It is a wound, and if you find yourself swimming in water that carries Weil's disease or some other kind of disease where you're being told not to swim with a wound, then fair enough. But in general, in the sea or in a swimming pool, I tell people not to worry about it and that they should get on with life, and that should include swimming if they want to. And some people worry that they're going to infect the pool. Well, you know, mucous membranes like the mouth and the vagina and the nose and so on are always underwater and producing bits of mucus, and that's coming out. It's massively diluted by the time it gets in the water. I tell people not to worry about that too. So swimming, fine by me. Another question that we had was whether there's anything that you shouldn't do if you've got a seton, and my answer from an activity point of view is that if something hurts, then it's probably sensible to try to avoid it or ameliorate the pain, and that might be, for example, saddle sports, cycling or horse riding. Those can be uncomfortable, although some people can do those fine with a seton in place, but they're not going to cause harm. And the only thing you can really do to cause harm if you have a seton is to pull it so hard that it damages, you know, cuts into tissues. That's really, really unlikely to happen because it will be tucked away inside your underwear or swimming costume or whatever. So in general, there isn't anything I tell people that they shouldn't do with a seton in place. That goes for sex too. Now, one question that we had was about giving birth, and that was with regards to a fistula and a seton being in place in a patient without Crohn's disease. The answer is, in my view, that it depends where the fistula is. If your fistula is round the back of the anus, then giving birth vaginally is probably no problem. If your seton is at the front and is sitting in the sphincter muscle in between the anus and the vagina, then it's a different story. And the concern here is that sometimes women can get a tear that runs into the muscles that surround the anus, through the back wall of the vagina and into those muscles. And a really severe tear can cut into the anus or rectum itself. And we think it is probably likely that if you have a fistula sitting within those tissues, that any tear which reached the fistula would be more likely to propagate through the fistula more rapidly. So I say to people in blunt terms, although I can't prove it with evidence, that I think it is more likely that they will tear, and even if it isn't more likely that they will tear, that it is more likely that any tear they have will be worse. Now that doesn't mean that they can't have a vaginal delivery, and some people really, really want one, and that's okay. But there is that risk associated with it. And if, in that view, they wanted to have a caesarean section, then I would suggest to them that I would be supportive of that, and I think that would be a very reasonable thing in the future. And a question that's just popped up associated with that: if you get a fix, could a future pregnancy cause another fistula even if you have a caesarean? No, if your fistula's healed, then being pregnant wouldn't make it more likely for that fistula to reopen, but a tear might still affect that area of weakness. But in that situation, a vaginal delivery is not quite so likely to cause trouble. If you had a caesarean section, it avoids all of that risk of perineal injury that we're talking about. Let me run through some of the questions that I've just seen appearing on the chat thread, if I can. Is there a high risk of cancer with a fistula? No. They've only been seen in patients with Crohn's disease, and even in patients with Crohn's disease, they are incredibly rare. The last time they were written up as a group, there were about 45 that had been written up across the world from different places over the last 10 or 20 years. So it is not a common problem at all, but that doesn't mean it doesn't exist. And we as surgeons and gastroenterologists have to watch out for that. Outside of Crohn's disease and inflammatory bowel disease more generally, it's not something that we see. And so for most people it is really not a concern. Anal sex with a fistula or seton. So I give the same advice in this setting as I do to women with vaginal fistulas, rectovaginal fistulas, having sex. Having penetrative intercourse with a fistula or a seton in place is likely to be uncomfortable and perhaps even painful. It doesn't worry me that the fistula is going to be made worse. Certainly with vaginal intercourse, I think we know less about that with anal intercourse. But I think it is reasonable to try at least gently to start with and to see what happens. And I think it is unlikely, without really vigorous intercourse, that an anal fistula will be made worse through anal sex. Having said that, I chat to patients about this very frequently, and my experience is that they can't do it. They find it too uncomfortable or painful, and the seton is too uncomfortable or painful for their partner, and so it isn't really a thing. And therefore, I really don't have evidence to support what I'm saying to you about that, and I can only suggest great caution. Goodness, questions coming thick and fast now. Let me refer back to a few that were asked earlier on. How often should a tight seton be tightened? So we don't do tight setons. We don't think they're a great idea because there isn't good evidence that doing a tight seton improves the continence impairment risk that you would see through laying open a fistula anyway. Although many people, many surgeons here in the UK and around the world use cutting and tight setons because if you go through the fistula more slowly, the theory is that the bit of muscle above will heal before the bit below separates. I think the benefit people get from these is actually more like sorry, I'm looking at my phone to look at the questions that are being sent through at the same time, and so it's slightly difficult to concentrate. But I will try and get to as many questions as I can. I think it's more likely with a cutting seton that fibrosis scarring allows the contour of the anus to remain more normal, and that probably helps with continence to some degree. But whether functioning muscle returns and heals once a fistula has been cut through with a seton is a separate question. They can also be very painful. The timing of the tightenings depends on the surgeon. There isn't any kind of stipulated rule about this, and probably the answer is the slower the better. But obviously if it takes too long, then all you're really offering a patient is a painful draining seton. Okay, I'm running in the chat thread now that I have on my phone so that I can try and ping through as many of these questions as possible. Right, well, there's been a couple of questions about pouches. Fistulas associated with pouches, J pouches, which are made usually for ulcerative colitis, occasionally for cancer-type diseases, but usually for UC, can be really problematic. So the first question is about a silk seton with a very active J pouch, emptying 20 times a day so that the seton's always wet. Is that a problem? The answer ought to be no. It's interesting that you have a silk seton placed. In general, people nowadays use the silastic rubber setons, the vessel loops that Lillian was talking about, or the ethibond setons that we use, and they're quite happy being wet. And they are wet most of the time because they sit within the anus, which is always producing mucus, and within the fistula, which is also full of stuff. So that's okay. I don't want you to worry too much about that. There was another question about J pouches. Can they ever be healed, fistulas associated with J pouches? And the answer is that they are very, very difficult to heal. It depends a little bit on exactly where the fistula comes from, and this is an area of research that Lillian is actually doing for us at St Mark's. Sometimes the fistula comes out of the join where the pouch joins onto the anus. Those are very difficult to manage. Sometimes they come out below the join and seem to be more like the fistulas that people get in the absence of pouches. They probably can be treated in the usual way, but we don't know if the outcomes are worse than they are for patients without pouches. And what we are uncomfortable doing is fistulotomy, lay open of these fistulas, which is the best way to heal a fistula. And that's because people with pouches, well, anyone with a pouch will know this, they need every single scrap of muscle that they can have within their sphincter complex, because a high output pouch will mean essentially having diarrhea the whole time, and the risk of continence impairment in those people with the loss of even a small amount of muscle loss can be more significant, so we tend not to lay them open. And we are not very good at healing pouch fistulas as a result. Draining setons can work their way through the muscle, in answer to another question, but they usually don't. If they do, it happens over quite a long period of time, and in general a loose seton is there to drain a fistula and to reduce symptoms, not to cut through. And if it's been sitting there for 2 years, as you suggest, then I think it would be reasonable to ask whether there are any other options for trying to heal this fistula, either fistulotomy or else one of the sphincter preserving procedures if the fistula is simple enough for it. Will we have a cure for fistulas in the next 20 years? That is an excellent question. My own view is that we're more likely to find a way to prevent them occurring after abscesses. And I've got 23-ish years left of my career, something like that. Depends a little bit on which governments we have between now and then, I suspect, in terms of when I'll be able to retire. But over the course of that time, I very much hope, and my research is aimed at trying to reduce the burden of fistulas, and partially that is through finding a way that we can prevent them from appearing when people have abscesses drained. Okay, okay, that's very helpful. Some surgeons in the UK do not do techniques such as lift or flap. Mine has mentioned it, but setons too. So I think it is reasonable, if a sphincter preserving procedure is suitable for your fistula, to find a surgeon who does that. And there will usually be someone in most hospitals who will try those techniques. And if there isn't someone in a given hospital, then there will be a referral centre within that region where there will be someone who will be willing to offer one of those techniques. Often the reason surgeons don't offer them is because the fistula isn't suitable for them. But if it is suitable for a sphincter preserving procedure, then I think it is perfectly reasonable to ask whether that can be considered. How do you know you have a good colorectal surgeon with a good understanding of these procedures? Often feel you just have to trust whoever you get. I think that is a really fair thing to say, and it's kind of difficult for me to answer. I think if you ask clear questions like, is there an option to heal my fistula? Is there a sphincter preserving procedure that could be used to try to heal my fistula? Then you ought to get a straight answer like, no, I'm sorry, your fistula is too complex, that just isn't possible, the only thing you can have is a seton. Or, yes, that might be possible, I don't know enough about it, I can refer you to someone who does. And I think one of those two answers is what it is reasonable to expect from a surgeon. Is there any harm in having setons long term? We've looked at that. Pouch. Right, lack of care post-procedures feels stressful. I completely hear that. Any advice on how to best care for yourself post-lift or flap? So one of the leaflets we're working on will be looking at managing your fistula in the post-operative period. In general, there is frustratingly little that you can do to try to reduce the risk of an attempt to heal your fistula failing. Keep the area clean, irrigate it from the outside with water is generally a very reasonable thing to do. Keep your stool soft and avoid straining. If you can do that, don't pick away at the anus or the repair, of course. Don't take up smoking, and if you smoke, give it up. Smoking and being very overweight are two things that we know have an impact on wound healing, and they are likely to reduce the chance that your fistula repair works. But apart from that, there really is very little you can do. And patients also often phone up and say, oh, I think my repair is failing. Is there anything that can be done? And the answer to that is, unfortunately, no. It will either work or it won't. And in general, the best you can do is cross your fingers and avoid anything which is going to stress the area and the wound, at least in the first few weeks, particularly with something like a flap, although with the others that's probably less important. Will I be stuck with a Seton with it being near 1 o'clock position rather than anus? Do I have less choices? I think a fistula at the front that sits between the anus and the vagina in a woman is harder. And the reason for that is that women have shorter anal canals than men, and in particular they have a shorter anal canal at the front, and it is more difficult to assess the muscle at the front. And so we tend to find that fistulas at the front in women are higher fistulas, even when they're not actually that high, than they are in men or round the back. And that means that laying open isn't possible, but it doesn't preclude many of the other techniques, most of which are still suitable at the front just as they are elsewhere in the anus. Complexity, though, if the fistula has branches, will obviously have an impact on that. Okay, cancer, anal sex, tears, we've done all of those. My Seton came out a month ago after being in 3 weeks. I'm waiting to get an appointment. Should I be worried? Okay, this is a good question. So it is not the case that as soon as the Seton falls out, you're suddenly going to get an abscess. But having a Seton in does reduce the risk of an abscess. Now, some people seem to get abscesses very frequently and quickly, and some don't. Some people go months, even years, without having an abscess. And so you will have a sense, perhaps, of which one of those people you are. In general, when people's Setons come out, we try to book them in relatively quickly, but that means weeks or a small number of months, usually, and in general, that will be okay. But of course, it is possible you get an abscess in the meantime. Shortening the time to you having an EUA and getting another Seton in reduces the risk of an abscess appearing in the meantime, but unfortunately, I'm sure that your surgeon, just like me, has a lot more patients needing an urgent operation than he has spaces on her operating list. So we are up against the system to some extent from that point of view. But no, you don't need to immediately worry. There was a question also that came in beforehand about how to tie Setons back together. I don't have a good answer to that. I think it's probably very difficult to do because they're very short lengths at that point. You could try a bit of dental floss and tie it onto both ends as like an insert in between. Some people tape them together. I've heard of people doing that and even gluing them together with super glue. All of those things are fine, but they ultimately won't work. And the fact is that eventually the Seton will fall out. So just make contact with your surgeon as early as possible and tell them what's happening, and they will ultimately try and get you in to replace the Seton. So lots of people are asking why they occur, and I feel like we could do a whole hour on that. But broadly speaking, there is a thing called the cryptoglandular theory. There are these little glands that sit around the anus between the two muscles about halfway up, and they produce the mucus that lubricates the stool and help it to come out when you're passing a motion. And we think that what happens is that bugs creep their way up those little canals into those glands where they sit, and it's like a little hot tub in there, you know. It's nice and warm, it's got a good blood supply, it's full of mucus which they love to kind of sit and swim around in and multiply. And the upshot of all of those is all of that is that you can end up with an abscess which grows and builds and becomes a big painful abscess which will ultimately burst. And it will burst in one direction or another, and it may or may not persist after the abscess has burst as a fistula. And for me, the big interesting question about etiology is why that persistence happens. Because if we can work out why the 5 in 6 people with an abscess don't get a persistent fistula and the 1 in 6 people who get an abscess do, then perhaps we can switch people from one to the other and kill fistulas at the point at which the abscess occurs. That's a really interesting area of Crohn's for me. Sorry, not of Crohn's, of etiology for me. Okay, Is there a protocol on the thickness of the fistula stroke seton opening for perianal setons? No, the answer is there isn't. I don't think you need a thick seton, even if the fistula is wide. The seton just has to keep the opening, the external opening, open. If it does that, the fistula will drain and you shouldn't get an abscess. And if you do get abscesses in that situation, it's because there's a part of the the fistula complex which is not draining properly. Lillian, I hope you're still there. I've just seen a thing that says, thanks very much, what's the email please? I wonder if you could copy out the email into the message bit there.
Yeah, just doing that now.
And then, great, well done you. Not a seton question, but I have a J pouch and fistula, anal canal to labia. Am I likely to have Crohn's rather than UC, or could this just be bad luck? The answer is that you might have Crohn's, and a group of patients who have a fistula associated with a pouch do actually have underlying Crohn's disease. There are 1 or 2 tests that can be done to look for evidence of that. In the past, people would have assumed that anyone in your situation does have Crohn's, but we don't believe that's true. It's important because of the nature of treatment that you might get in association with a Crohn's fistula versus the others. The answer is that an assessment of the fistula, the pouch and the small bowel upstream should help to give an answer about how that should be classified. And Lillian's written a paper which talks about the classification of pouch fistulas, which will be published, we hope, in the next 2 or 3 months, which will hopefully help other surgeons around the country and the world to get a handle on this. I have a transfincteric horseshoe, lots of operations and different setons due to branches. I don't have Crohn's or any other bowel issues. Is it worth just living with setons? So that is a really great question. And the answer always is there are 3 choices to manage these fistulas. One is to lay them open, but that carries a risk to your continence depending on how high the fistula is. The next is to live with long-term loose setons, and that has the benefit of not damaging your continence, keeping you out of hospital. Once we've got good control, it means that you can get on with life, and the worst part of the whole thing, other than the setons themselves, should be discharge. But that doesn't happen for everyone, and some people have pain despite that. The third option is to try and get the fistulas to heal, but with a horseshoe you have to rationalise the fistula first, get rid of the horseshoe so that you can then treat the underlying straight fistula tracts that you produce. And even then, the techniques we use to try and heal these things don't always work. And so many people will end up with setons, either by choice or because everything else fails them. And in that case, they'll stick with the seton. And for many people, that is a really good way to have their fistula treatment, because it means they stay out of hospital, we don't damage their continence, their fistula's well controlled and they can get on with life. But as I say, that isn't the case for everyone, and some people need further surgery to try to produce that very well controlled situation. Is VAF likely to stop drainage? No, I don't think it is, unless it heals the fistula. We sometimes use VAF to heal the fistula, and we sometimes use it to reduce symptoms like drainage and pain, but I think it rarely stops it completely unless you've managed to get the fistula to heal. Is there a general anaesthetic needed to place stroke change a seton? Yes, I think there is. I think it probably is possible to do those things in a clinic. If the seton is small and can be passed through the fistula without too much discomfort, but I don't think that's particularly common, particularly with the silastic setons, which tend to be quite bulky. So I think in general we have to assume that a general anaesthetic would be needed to change a seton. It is certainly needed to place one every time. Does having a rectocele make repair of a transfincteric anal fistula more difficult? No, shouldn't do. Depends on the type of operation that you do in order to fix the fistula. It would make a rectovaginal fistula more challenging to repair, but it can be repaired at the same time. So the answer to that question is it depends on the specific anatomy. You mentioned general care after a flap. What do you suggest? I think after a flap you want to allow the flap to heal, to really stick down to the bed of tissue that you have put the flap onto as much as possible, and that means not stressing the area too much. So I tell people not to do things like horse riding or cycling or to lunge, and to do anything that's going to stretch, twist, stress the tissues of the anus in that setting for the first 3 weeks or so, perhaps even longer. Aside from that, don't smoke, lose weight, eat healthily, keep your stool soft and avoid straining. And those are probably really the only things that you can do. Keep the whole external area nice and clean. You'll be left with the external opening wider than usual so that it can drain well, and that's a good thing. Keep that area open, wash it with the shower hose. Does having a fistula make it more likely to, it says drop Crohn's. I presume that means develop Crohn's. The answer to that is no. But fistulas are more common in people who have Crohn's disease, and so if you have a fistula and you have Crohn's type symptoms, then we should be searching for evidence of Crohn's disease through assessing the bowel, the lumen of the bowel. How often can silver nitrate be applied? Yes, there were questions about silver nitrate in the ones that we received beforehand. The answer is as often as you like, but in general, you would use it and then wait for a few days for that area of granulation tissue that you've treated with the silver nitrate to slough off. And then if the granulation tissue comes back, or if more is needed a few days later, fine, go ahead and do some more. In general, you do it pretty infrequently just to try and keep the granulation tissue under control. And if there's lots of it so that you're needing it regularly, then it may be worth debriding the tissue. But if the granulation tissue isn't particularly bothering you, it's also not that big a deal. It doesn't cause any harm or damage, but it can be irritating. Is there any way to access stem cell treatment on the NHS in the UK? No, not at the moment. NICE said that there was insufficient evidence to support its use for the time being. So the only way you can get hold of it now is in a clinical trial, and there is one called Admire 2, which is starting in the UK this year, and there are a number of centres all over the country that will have access to it. We are one, but there are other places like Sheffield and Cambridge and other places all over the country. And chat to your local surgeon if you are a Crohn's fistula patient, who should be able to tell you where your most local centre is. And if they probably won't know off the top of their head, having said that, they'll need to look it up and get back to you. Is packing of a wound beneficial or not? We say not. We don't like packing. We think it's unhelpful. But you do want to prevent the mouth of the wound from healing up before the base of it does. We call this healing by secondary intention, meaning from the bottom up. And so we advise people to digitate, rub the wound with a gloved finger or a bar of soap, just to irritate that wound, to rub it, to frustrate it, to stop the skin from healing, to get rid of the granulation tissue and to allow it to heal from the bottom up. That seems to us to be the best way to do it, although again, that's been our experience for a long time, but it is without evidence. Is flaminol a better packing medium? I haven't come across flaminol. In general, we just don't pack. Do you have any advice on the most effective biologics for a perianal Crohn's fistula? The best one, according to the evidence, is infliximab, and that's usually in combination with an immunomodulatory drug like azathioprine. These are not suitable for everyone. Sometimes they stop working, sometimes patients develop antibodies to them, and so others like adalimumab and some of the others too do seem to have some benefit, although it probably isn't quite as good as infliximab. In general, though, it isn't just the drug. It's about getting the whole fistula complex well drained, getting good setons in, trying to control the luminal disease as effectively as possible, using these combination drugs like infliximab and azathioprine, making sure that the drug levels are good. You probably need higher than usual drug levels in patients with perianal Crohn's disease to achieve the optimal outcome with them. And even then, sometimes it doesn't work, and there are patients who need much more radical steps like stomas and proxectomies. But in general, the best of them is infliximab. Can a flap or lift only be tried once? Does it cause scarring? It does cause scarring, and it's more difficult second time round, but it is possible to do things like lift and certainly flaps more than once, depending on the nature of the tissues afterwards, depending on how the recurrence has occurred. It can sometimes make things worse and more difficult to do second time round, so it's not always effective. But it is sometimes possible to repeat them, and there are other techniques that can be done if lift and flap aren't suitable second time round. Is it normal to bleed from the external opening when the Seton exits? Yeah, that does happen, particularly with granulation tissue, which is very fragile and can sometimes bleed. And bleeding per se is not something to worry about, particularly if it's small amounts and happens intermittently. Sudden changes in things like bleeding are always slightly a concern, particularly in Crohn's disease, but in general, and it's worth mentioning to your surgeon the next time you see them, but it's not something to get too excited about. There's a lot of anxiety about bleeding from fistulas, but we see it quite a lot, and if it's relatively small amounts, then I don't get too anxious about it. No Crohn's or conditions. Abscess caused high fistula with branches. Can high complex fistulas ever be healed? They can, but it depends on the nature of them, and there are definitely high complex fistulas which will never be healed. And I sometimes tell people that they have what I consider to be an incurable fistula, and those ones I will work hard to try and make as asymptomatic as possible with Setons in place so that they can get on with life. The fact that a fistula can't be healed doesn't mean it can't be helped. And a very symptomatic incurable fistula is one that should be treated. And it may be that it should be treated with further drainages and additional Setons being inserted until you get to the kind of situation where the patient is actually comfortable, the discharge is improving, the abscesses aren't occurring, the pain is less. And it is usually not always possible to achieve that. And that is certainly what we should aim for, in my view. I have 3 abscess points, 2 alongside the labia, 1 just in front of the rectum. I have 1 Seton placed. Will the other 2 abscesses continue to be an issue? The answer is probably yes. And it may be that those 3 abscess points can be laid open, because they are probably all meeting outside the sphincter complex. But sometimes they will cross the sphincter complex in different places, and in that situation they might have to have additional Setons placed into them, and you may not want them to be laid open because of where that cut would be, so additional Setons would be a reasonable thing to do in that situation. Can a cutting Seton make things worse? So my anxiety about cutting Setons is that they can lead to an impairment in continence, and that is probably a conversation you've had with your surgeon, and you will have taken a view on the risks and benefits, and it's really difficult for me to answer this because I don't do it. But if you've had that conversation, your surgeon has explained to you what the worst case scenario is associated with a cutting Seton, and you take the view that that is a risk worth taking in order to get the Seton healed, if that's, that will have the chance of it being healed, then it is a reasonable thing to do. What options other than a flap or advancement flap are there? So lift and flap, and then a bunch of other newer stuff which probably aren't quite so effective. Evidence to support them, and that's things like plugs, VAFT, Phylac, which is the laser, and so on and so forth. None of them are so good, none of them has as much evidence behind them, and people do them far less frequently as a result, but there are other things that you can do, yes. So there's a question here about the webinar and whether it will be available to view online along with the Q&As. I think the answer to that is yes. And I think Gillian and the guys will post that in the group. I'm going to answer whatever questions are left, and then I'm going to hand over to Gillian to speak, if that's okay, just to close things up. So, after a failed flap and failed lift, would it be beneficial to try a flap again? It's an option to try a flap again. I guess the chance of it working the second time round is less, and whether or not it is feasible will depend on the tissues. If they're very scarred, then it just won't be possible to repeat the flap. But after a sufficient period of time, assuming that the tissues soften up, and your surgeon will be able to assess that, it wouldn't necessarily be impossible to try it again. But in some patients it is impossible because the tissues are too scarred from the first attempt, and the chance of it healing a second time are certainly lower than the first time. Best time frame to leave Setons before future surgery. I tend to wait 2 or 3 months. That's a tussle. I'd like it to be as long as possible. Patients want it to be as short as possible. And 2 or 3 months is where I settle as probably being about the right amount of time. The truth is that we don't know. And sometimes we take patients to theatre after 2 or 3 months and it's still a very active inflammatory fistula, and in that case I would not do the attempt at fistula repair, would scrape it out and leave the Seton and wait another several months to see if it will settle down. Okay, Gillian, can I hand over to you to wrap up?
Hello, it's actually going to be Rebecca. We've changed our plan. That's all right. So that is everything for today. Thank you very much, Phil and Lillian, for giving up your time. It's been really appreciated. I think everyone's found that really useful.
Thank you for having me.
Thank you very much. We had hundreds of questions flying in. Well done, Phil, for bashing through as many of them as possible. And thank you to Rach, Gillian and Lindsay for helping moderating and sending over all the questions to Phil as well. Apologies for any technical problems we may have had going on. It appears there were some people that couldn't hear and things like that. So for next time we'll try and update the instructions to maybe make it a bit clearer so that everyone can hear. We have tried to record this, so hopefully it will have worked, and we'll be able to upload it to the groups afterwards, and then we'll provide any of the Q&As on there as well. And just to mention, in a couple of weeks' time, we have actually got another webinar on rectovaginal fistulas that Phil will be hosting with another member of his team. I will post the date on the group as soon as we got that confirmed. But other than that, thank you very much, and thank you to everyone. You can all log out now just using the leave button either at the top or the bottom of your screen. Thank you very much, Phil and Lillian.
Thank you.
Cheers.
Thanks, Rebecca, Gillian, and all the team for putting this on. It's an enormous amount of work has gone into making this a smooth, so well done to all of you guys.
Thank you. Cheers. Bye-bye.
Bye-bye.